Hello, everybody. Thank you for joining us on this second webinar organized by GECO Spine Institute and Spine Innovation. I am Olivier Ricard, orthopedic and spine surgeon in Luxembourg, and it will be my pleasure to moderate this session of 1 hour dedicated to sagittal balance and disc arthroplasty. Spinal alignment is one of our major concerns in spine surgery, especially when we perform fusions. But don't we pay so much attention to spinal alignment in artificial disc replacement? We don't usually expect, after a disc replacement, major changes in sagittal alignment, especially as long as the spine was well balanced prior to surgery. So those spinal alignment really matter in disc arthroplasty. As we're talking of motion preservation technology, don't we have to evolve to another concept of spinal alignment? I would say a more dynamic definition than its usual static definition. To share experience and knowledge in this matter, we can discuss all these questions with three outstanding speakers and experts, and I will introduce them. The first one is Alexis Perrin. He's an orthopedic and spine surgeon practicing in Lille, France. He will give us a review of literature about this topic. The second one is Professor Jean-Yves Laznec, very well-known and experienced spine surgeon from Paris. His mentor was Professor Wakami, who everybody knows for his main contribution to spine surgery, inventing the pedicle screw. Jean-Yves has published a lot of papers about spinal alignment, especially the relationship between hip and spine, and also many papers on biomechanics of either mechanical and viscoelastic disc arthroplasty. The third one is Professor Svante Berg. He's the most skilled and experienced surgeon in spine arthroplasty in Sweden. He has used different artificial discs, mechanical and viscoelastics, and he will share with us how he takes care of the spinal alignment in his daily practice before and after a disc replacement. This webinar is intended to be interactive. We can immediately start the first poll. The first question is, are you using disc prosthesis? 64% of users of disc arthroplasty. The second question is which area we are using this prosthesis, in lumbar area, cervical area, or both. We have a very equivalent distribution of users in the lumbar level, cervical level, and both, so 33% for each category. And the third question is which type of prosthesis you are using, mechanical or viscoelastic. 56% of users of viscoelastic prosthesis and 44% for mechanical. So we can move on the first lecture. So I ask Alexis Perrin to open this micro.
Hello, everybody. Thank you, Mr. Ricard, for your introduction. I would like to thank Eric Herman for having asked me to participate. And now let's talk about literature concerning sagittal balance and disc arthroplasty. Here my disclosure. If you want to learn more about the different prostheses that have existed and their evolution, you can watch the first webinar of GECO Spine Arthroplasty, where Professor Marc-Antoine Rousseau has been talking about the different types of arthroplasty. For those who prefer to read, you can have a look at a very exhaustive review and history of arthroplasty written by Fahem Sandhu. Here is a table where you will be able to see all the different models of lumbar disc arthroplasty and the main study about each prosthesis. Concerning sagittal balance, we can separate 4 types of balance spine according to Rousseau classification that you can see on the left, with low and high pelvic incidence. If you want to learn more about concerning this interesting subject, you can read a good article by Leuec, which reviews the different elements to understand sagittal balance, like pelvic incidence, SVA, SSA, and T1 pelvic angle that you can see on the different figures. Understanding this data allows for better planning of surgical management of the patients and permits us to understand the complications like Johnson syndromes. Disc degeneration can lead to a lumbar hypolordosis or kyphosis, which may be the cause of an anterior sagittal imbalance. So the goal of this review is to define when the arthroplasty is a good indication in this case. I search on PubMed, and when you associate sagittal balance and disc arthroplasty, you can find 37 results, with 8 results during the last 5 years concerning lumbar or cervical. So now let me present you the main results. The first one I selected is a meta-analysis of 59 manuscripts included after a thorough selection, and comparing functional scores and sagittal parameter with the aim to answer when the TDR is a good alternative to fusion. Lasnek and Loek found the same results, only the segmental lordosis significantly increased, about 10 degrees, and remained stable. No other significant variation, even in global lordosis, and no statistical difference comparing parameters between the two groups of TDR at 4.5 and 5.1. Concerning Tournier, his results differ. He concluded that the mean lumbar lordosis significantly higher after total disc replacement, and the increase of L1 S1 lordosis is neither linked with an increased angle at the prosthesis level, nor with an increased range of motion at the prosthesis level. Concerning Berg, he found significant differences in the fusion group at adjacent segments, with more translation and flexion extension, which is pejorative and can induce adjacent segment disease. Pelé and his colleagues studied the spinosacral angle that you can see on the figure to study sagittal balance. He compared it between fusion and TDR and found significant increasing for TDR contrary to the ALIF group, even if a lordotic cage of 12 degrees was used. So he concluded that arthroplasty appears to work most effectively at L4, L5 for all back types, because it provides a better control of sagittal balance and better clinical results without affecting the lordosis of the underlying L5, S1 segment. He advised for elevated sacral slope to use at L5, S1 arthrodesis, which seemed to be more suitable. Here, the sources I used, and now a study by Strub comparing Russoli's sagittal profile for TDR at 4.5 and 5.1. He found no change of the global sagittal profile compared with the pre- and postoperative X-rays, and significantly inferior scores for pain and function for sagittal profiles type 1 and 4. So that he concluded of a relative contraindication for lumbar TDR because of higher shear forces or loads on the posterior structures for these sagittal profiles. Another study, Maybloom and its colleagues studied the position of a mechanic prosthesis and found no significant association between anterior-posterior placement and the postoperative sagittal balance parameters. It determined a better functional outcome when TDR was positioned anteriorly to the center of the vertebral body, but these results concern a semi-controlled arthroplasty. He concluded that patients with normal preoperative lordosis had the best functional results, and TDR allows the preservation of a pre-existing balance. To conclude, for lumbar, TDR is a suitable alternative to lumbar fusion. It permits to prevent an ISD, the percentage that I found, and permits also compensatory mechanism. But we have to take care with these results because many studies with mainly mechanical prosthesis and no comparison with elastomeric prosthesis. Only standing full spine radiographies and no sit-in radiographies. Jean-Yves Lasnek going to talk about that. For finish, no advice concerning frontal disorder. Now let's talk about sagittal balance and cervical disc arthroplasty. Altered cervical alignment is a crucial factor in the progression of cervical myelopathy and adjacent segment disease and neck pain. OC2, like you see on the left, and C2, C7 angles work inversely. The C7 slope has a predictive value for the shape of the cervical spine in the sagittal plane. The median value is about 20 degrees, and patients with a C7 slope greater than 20 degrees have a lordotic cervical spine. Two studies comparing TDR, hybrid surgery, and fusion in multi-level cervical discectomy. On the left, the first one found no significant difference concerning global lordosis among the groups, but the authors determined for 3 or more levels a good clinical outcomes with TDR. And they conclude that TDR was not a good choice for large preoperative C2, C7 SVA, contrary to hybrid surgery that provides good cervical range of motion and restore cervical lordosis and C2, C7 SVA, but we must be careful because there was no significant results. In the second study on the right, the author found that cervical alignment was equivalently rebuilt among the groups. And the clinical outcomes were not related to the change. So he concluded that it was not essential to pay excessive attention to cervical balance. A last study published in 2020 concerning a viscoelastic prosthesis, they found that at the follow-up, there was no significant modification of the SVA. Thank you for your attention.
Thank you for your nice talk. I have just a question of the chat about this. What is really a viscoelastic prosthesis? What is the definition? So
the big difference is a question of center of rotation in my mind and functionally. And the other aspect is, of course, the design of the prosthesis, because mechanical prosthesis more or less have wear surfaces, because you have sliding, you have, in fact, you have 5 degrees of mobility, and with viscoelastic, you add a bumping effect. This is for the design. And regarding the functional aspect, the big theoretical advantage of the viscoelastic implant is to have no fixed center of rotation. It was one of the topics we developed during the last webinar.
I agree on what you say, and one might say that a mechanical disc prosthesis is totally loose. It has to be stabilized by the soft tissues, the ligaments and muscles, while the viscoelastic one has an inbuilt resistance to mobility. That is a feature of a healthy disc as well.
Do you think that a full spine X-ray in standing position is mandatory before a disc replacement in a daily practice? And if yes, what kind of information is more relevant for you to consider from this X-ray?
Yes, I think that the standing full spine is very important because it permits to decide before to implant a prosthesis, because it's the only one to permit to determine the sagittal profile, and so that we can see SVA. So these very important things are necessary to make the decision if we want to put a prosthesis or not. As we see on the literature, there is some relative contraindication to put before to put a prosthesis, like an imbalance or Rosoli profile 1 and 4. And on the full spine X-ray, you will be able to see upper deformation or the explanation why there was a sagittal imbalance. So yes, for me, I think it is very important.
So we will move to the second voting on the poll. So that's about the sagittal alignment. Do you ask for a full spine standing X-ray before and after an artificial disc implantation? So you can vote now. Oh, it's nice. 100% of attendees are saying yes, we ask for a spine standing X-ray, a full spine standing X-ray before disc prosthesis. So we can move now to the second lecture from Jean-Yves Lasnek. Jean-Yves will give us his interesting point on a more dynamic approach of the spinal alignment, which seems to be required as soon as we speak of disc arthroplasty. So Jean-Yves, can you share your screen now and open your micro?
So I have 8 minutes to convince you that it is very interesting to have an idea of the sagittal balance, but not only in standing position. You have here different examples of mechanical and viscoelastic implant, mechanical on the left, viscoelastic on the right. And you see we used to sitting X-rays for lumbar spine. Until now, we see a lot of patients, mainly with CT scan or RMI, as a main tool to decide about a disc replacement. I am not convinced it is a good thing, because we need to have a local, a segmental analysis of the implant, but also a global analysis of the implant. During the last webinar, we have developed the concept of the range of motion, sagittal rotation, and translation. And also, we have spoken about the location of the mean center of rotation, as you see on the left animation with the arrow. Alexis did a very good paper showing that regarding the lumbar spine, there is no significant changes between post-op and pre-op alignment. It is very interesting, because the message is, with a disc replacement, we cannot do a palliative of sagittal malalignment. But there is another aspect. It is also, in a way, a predictive tool to do preoperative X-ray, a predictive tool to understand how the prosthesis will work after implantation. We have here some example of full body EOS. I have the opportunity to have a lot of EOS images, so it's very interesting to demonstrate this. You have patients with different pelvic incidence, and in yellow, we are accustomed to look at the sacral slope, and you see before pre-op and post-op, no significant change. But I want to convince you that the balance analysis is a dynamic concept. Case 1, case 2, and case 3 are very different, and we know this from the hip surgeon, in a way, because we know that during sitting position, we have a retroversion, ideal retroversion case 1, case 2, patient with a stiff retroverted pelvis. And the right case is also very interesting, because some of our patients with disc problem have hyperlordotic deformity. So what is interesting is to detect the case 2 and the case 3, because we know that case 1, it works very well. So what about the sitting position? We know that the sacral slope decreases when sitting. We also know that the angulation of the disc changes. How to see this very quickly on the images? You see the convergence of the red line showing the end plates of the prosthesis, and you see that when the prosthesis becomes flat, the convergent point is very posterior. Not in all cases you will see, but this is a case of a standard viscoelastic implant. So some of our patients have a normal kinematic of the implant, but they are very different. On the left side, you have a patient, you can call him a spine user. You see, with sitting position, he has no complete hip flexion. On the right, this patient has 2 hip replacements. She has a mechanical implant, and you see that she is a hip user, using a lot hip to sit. So there is a balance between the mobility of the hip and the mobility of the spine. So you can say to me, okay, in theory, and nothing changed standing. What about sitting? Sitting position, the same. When you ask a patient to sit after a disc replacement, in most of cases, there is no significant change of sacral slope. I have no time to show you a lot of data, but you can trust on me. It's true. Like in this case, for example, you can say to me, between pre-op and post-op, changes of sacral slope are not very different, but look at the hip. And so I think spine surgeon must look at the hip. And you see that after the prosthesis, this patient used less his hips than before, probably because he is less painful. So we have different type. We know that standing and sitting, no standard modification between pre-op and post-op. But our patients are very different. Look at the case on the left. This patient has a huge modification of the global lordosis between standing and sitting after his hip prosthesis. On the right, you see no important delordosis. So it means that the modification of the angulation of the disc is not so important. What does it mean? It means that you have less constraint. You are not asking as much to your implant. So it is interesting to look at those patients with a huge modification of the retroversion, huge modification of the curvature. Perhaps type 4, as Alexis said to us before. So what happened? You have here a standard patient, 50 degrees pelvic incidence. This image is taken from the morphing of EOS, and you see between standing and sitting, you have a decrease of the angulation. It is a viscoelastic implant, and you see the modification of sacral slope. Now we look at a low pelvic incidence patient. As spine surgeon, we know that the pelvic retroversion is more important in standing position, so the sacral slope is less. And in sitting position, sacral slope is also less than with standard pelvic incidence and even negative. Now we look at the same standard pelvic incidence patient. You see the variation of sacral slope, very typical. And now you see a high pelvic incidence patient, and you see there is a much more important modification of sacral slope. So probably more, we are demanding more to the implant. Look at those two cases. On the left, you have a mechanical implant with a low pelvic incidence. What is surprising to you is to see where is the convergence point of the end plate. Very often people say, I use a mechanical prosthesis, and by the way, it will adapt itself. You can see in this case, because this patient has an atypical adaptation due to low pelvic incidence, the angulation of the prosthesis is modified in the wrong way, in a way. On the right, you have a patient with high pelvic incidence, huge modification of the global balance, and you see you are demanding much more to the viscoelastic implant. So we have the functional aspect of standing to sitting, but we have also probably structural problem due to the pelvic incidence. Now moving quickly to the cervical spine. I think something very important for us coming from the images is the T1 slope, as Alexis said to us. And there is another parameter, because you have patient with low T1 slope and patient with high T1 slope. And we have also, but we are accustomed to this as spine surgeon, we look at the C2, C7 sagittal angle. It's not theory, because this is a case pre-op. You see that this patient has a high T1 sacral slope. So we need to have preoperatively such X-ray, not only doing basic dynamic X-ray, we need to look at the T1 sacral slope. And you see here how different is the position of the implant between high flexion and high extension. And this raises the idea of the extension reserve and the flexion reserve. Not all of the patients are the same for extension reserve and flexion reserve. Look at this patient, for example, it is a mechanical implant. You can see the adaptation of this implant. It works very well. This patient is not painful, but this alignment is a little bit problematic. And look at the center of rotation with this black arrow. You see the center of rotation is not correct because it is inside of the prosthesis. So probably problems to come by the time. Another case with high pelvic, high T1 slope, and you see the same risk with center of rotation inside of the implant. Now, low T1 slope, I want to convince you to look at this T1 slope. You have lower level of kinematic stresses on the implant. You see, because you have less extension reserve regarding the standard position of the patient. Here, another case, pre-op, post-op, you see, you have less extension ability. So probably you cannot promise to the patient full range of motion. Look at this patient, for example, you see this strange adaptation. We cannot believe using loose implant, a mechanical implant, to provide a self-correct adaptation in all cases. Look at this case with a viscoelastic implant, the same problem. We are facing the same problem, less extension ability. but with the advantage of no fixed center of rotation. So the center of rotation can move outside of the prosthesis. Now, quickly to finish, cases with 2 levels. As a demonstration, I only use cases with 1 level. You have here a patient with high T1 slope, and you see the location of the center of rotation. And not all is pink, because you see that when we have 2 levels of implant, sometimes there is no perfect center of rotation, but you see the center of rotation is different for extension and flexion. And here, cases with low T1 slope, and you see the center of rotation, we must look at this. We should have now the tools to analyze this center of rotation. So what are my UMIL message? First, it is important not only to use CT scan or RMI. The problem is not to replace deteriorated disc. We must analyze the sagittal balance as a dynamic concept. Despite there are few variations between post-op and pre-op. The fact that there are few variations is a good predictive information regarding the future of the prosthesis. At the lumbar spine, you don't need EOS. You need only sitting and standing lateral X-ray, and you need to look at the pelvic incidence. Be aware of the high pelvic incidence patient, but also to the low pelvic incidence patient. Remember my 2 cases. And cervical spine, no EOS. You need to do flexion extension X-ray. You need to look at the T1 slope. You need to detect if the patient has a flat cervical spine. What is preoperatively the extension ability. Knowing this, you know better the risk of slipping or excessive translation. Thank you for your kind attention.
Thank you, Jean-Yves, for his nice talk. It's very, very interesting. I think there is a lot of new ideas on this matter. So I am just looking from the chat if we have some questions. We are all trying to fit the sagittal balance to the patient, or not the patient to the sagittal balance. What's your comment about that?
I think we have moved to the idea of obtaining range of motion. Range of motion is not only sagittal rotation. Range of motion is translation and sagittal angulation. The second step is to understand our patient. Probably we have patients where it is more complex to adapt the prosthesis, and where and those outliers may raise some problems. What is interesting, as Svante said before, with viscoelastic implant, the implant is in a way provides some limitation of the adaptation. So we must add this an analysis of the sagittal balance to know if we need to use a very lordotic implant or a less lordotic implant. Personally, I did mistake at the beginning of my experience using 2 lordotic implant in low pelvic incidence patients. And those patients are very fascinating. They have no facet problem, because we know that viscoelastic implant protects the facet posteriorly. But we can see that there are modifications of the biomechanic of the upper disc. And probably we need to be very careful regarding this.
So we are going to move to the poll, the last question. Which design of prosthesis would better guarantee the restoration of sagittal balance? Viscoelastic, mechanical, no difference. So you can vote. And so we have 83% of people saying that viscoelastic prosthesis guarantee the restoration of sagittal balance versus no difference in 14%. So we move on the next talk now from Svante Berg. So Svante will give us a specific approach to spinal alignment. I would rather say the muscle imbalance, which is supposed to be fixed by an intensive physio program prior to disc implantation.
Thank you, Oliver, for introducing me, and thank you, GECO, for letting me present here. In my mind, sagittal balance is something that is very dynamic. It's not something that is fixed forever. And that is the item of my presentation today. I have nothing to disclose. When this generation starts, it slowly increases degenerative changes in the disc, and that alters the mechanical features of the disc. Often the patient reports a sudden onset of symptoms at loaded situation, and that is why many patients believe that this is traumatic, they have an injury, but it's not. It's a time thing that suddenly the mechanics were bad enough. This often leads to reflectoric tension and cramp in erector spinae muscles. Since they work all day long, they get stronger, and this might create a increased lordosis at the segments of degeneration, and then that creates further pain. Then the patient enters a vicious circle where the patient feels tired in the back muscles since they are always tense. They might be having more training and exercise to make them even stronger. Then they get even more segmental lordosis, and eventually that starts also to injure facet joints. And they develop a muscular imbalance with much stronger posterior muscles than the often weak abdominal muscles. And if this is not dealt with, the patients will not have the benefit of TDR treatment. And the benefit is the ability to alter lordotic curve according to position, just as Professor Lasenek told us about. With fusions, we normally perform a lumbar fusion and we decide the lordotic curve that the patients will have all their life. This curve is calculated to be a nice curve for standing, but the patients do a lot of other things than standing, for example, sitting, and then the curve doesn't fit in. And this might cause primarily muscular pain and fatigue, but over time also tremendously increased risk of adjacent segment disease. That's why I've been doing this now for 25 years or a little more, and we've come to the conclusion that the patients have to have a preoperative program. This is to define what curve is it actually on their spine. What is a change over time by this muscular shortening, and what is actually their structure. How much have their dynamic lordosis changed over the years with low back pain? Most of the patients that reach us have had pain for quite a while, as you know. So we give these patients, before surgery, an intense program for strengthening of the rectus abdominis muscles and stretching, lengthening of the erector spinae muscles. And those stretches for the erector, they have to do like sitting at the desk or whatever every 50 minutes to really change it. And we recommend them to sleep in a fetus position so they stretch out a little in their erector muscles during sleeping, and at least don't let them contract further. And as you probably know, all this has to be done anyway to get a good cervical result, because if the patient comes back after surgery and have a lot of muscular pain, the gain is zero. So this has to be done anyway, and it's beneficial to do it, most of it prior to surgery. In the preoperative evaluation, before I even decide to what type of surgery I would recommend the patient, I would look at the curve according to the Russelli scores and see what it looks like. And from those curves, I might say that this has to be a hybrid. The lumbosacral angulation is too high, so I have to make an angle, a lordotic ALIF and a TDR. But before deciding on that, the patient has to try to get back to what was believed to hers or his original sagittal curve before pain started, since this is very dynamic. On a preoperative evaluation, on the left, you can see a case with 2 discs, mechanical discs. This patient managed to stretch the posterior side and strengthen the anterior side, so he or she could have a mobility in the spine. And on the other side, you see a case where there was the patient was not able to change the angulation at L5S1, so I did an A-lift there, but put a disc on top of it. And this is how things might fall out when you see these patients coming back after their preparations. Then we have to realize that during surgery, we implant cages or disc prosthesis on a disc degenerative segment. The disc is lower than it was when it was healthy, and we restore disc height suddenly. Then all the posterior structures get too short again. So with a mechanical TDR implant, it might tilt over. It's a high risk of that, and that puts a high load on the facet joints and probable further pain from them. With a viscoelastic implant that saves the facet joints, since there's a counterforce in it, there will be strain and pain in these muscles anyhow. And that is why, even if primarily happy after surgery, the patients have to do their stretches for at least 6 months after surgery to conserve and maintain a normal balance between posterior and anterior musculature. This is not to limit mobility, it's merely to reduce a painful battle with muscles that affect the lordotic curve. If you see on this patient, on the flexion pictures, this wouldn't be possible if the patient hadn't stretched their lumbar muscles prior to surgery, because this is taken short after surgery. And still, there's a nice ability to have extension in the back, of course. And that means that the patient can adapt to different positions, can adapt to one curve when standing, another at sitting, and so on, without a lot of soft tissue limiting it. Sometimes it's just too late for TDR at a segment, even after the pre-op preparation. As you can see on these pictures, this patient with 2 segments of degeneration, with the lowest one severe, managed to restore mobility at the lower segment, but it was still too arthritic at the facet joints and so on to be meaningful to put a disc in, even if there was mobility after the preoperative preparations. So I did a combined, I did a A-lift, angled A-lift, and put a disc on top of it. We have to provide our patients with tools and instructions. To make TDR surgery meaningful and successful, we have to engage the patients to do their homework prior to surgery as well as after. It's not a quick fix to have surgery. They have to be heavily engaged to give the good result. And to give them the right instructions, we need to cooperate with a skilled and educated physiotherapist. Some of that physiotherapist education you have to provide, because she or he has to know the goals to meet in the preparations. But this will give the patient the tools to take care of the lumbar spine. I'd like to thank GECO for letting me present, and all the audience and the panel for listening. Thank you.
Thank you, Svante, for your presentation. So I will ask you how you can manage to make this huge program of physiotherapy before surgery in very painful patients. We have some patients, as you know, very painful with modest changes on the end place or very huge central disc herniations. How you can manage to make this physio before surgery?
I think that it's possible because they understand that both me and my physio really believe in this, and after just a couple of weeks, they actually mark themselves that they get less pain when they get rid of the part of the pain that is muscular. Then they are stuck with a discogenic pain, but that is only part of their total pain syndrome. Of course, if they have a giant central disc herniation with a lot of nerve compressions, there isn't time to do this. Then we have to do much more afterwards. But in most cases, we have the time, and we put the driven up what they have to achieve before we do the surgery.
As you have used many different types of prostheses, I understood that you are using more viscoelastic prostheses. Did you find a difference in the length of this physiotherapy before and after the surgery compared with the mechanical prosthesis you performed before?
I think that the patient's muscles are as stubborn whether they get this or that prosthesis. But the thing is that if they are lazy, if they don't deal with it, with a mechanical prosthesis, there's a high risk they will get back to me in a couple of years with facet joint arthritis. The patient with viscoelastic prosthesis would probably not suffer from that, but they are not as good as they could be because they will still be troubled by cramps in their lumbar muscles, tiredness, stiffness, things like that.
So we are touching the end of this session. It's very, very quick. So we will move maybe to the take-home messages from each speech. Okay, so summarize the different speeches. The first one for Alexis Perrin: don't use a disc arthroplasty to correct a sagittal imbalance. TDR allows the preservation of a pre-existing balance. Patients with normal preoperative lordosis had the best functional results. From Jean-Yves Velaznek, spine balance is key for the analysis of the artificial disc function. And from Svanteberg, do not make a definitive pre-op conclusion on the lordotic curve until the patient has dealt with the changes from long-time low back pain. Realize that the restoring this phase will shift the segment towards in extension. To summarize, do you think that extreme incidents are not good indications of this prosthesis, as the behavior of the prosthesis will be unpredictable?
I think that, remember my three small movies: the standard patient, standard incidence angle, normal curvature, no problem. And it is the majority of our cases. Then you have the patient with a kind of flat back and the patient with a hyperlordotic spine. And we must ask ourselves, is it due to a structural problem due to pelvic incidence, or is it due to a muscle problem? And the paper of Svante is very interesting because looking at those patients with hyperlordosis must make us think about a muscular problem if we don't have a high pelvic incidence anatomy. So if I have a patient with a low pelvic incidence, it is not a contraindication for an implant disc replacement. We must avoid an implant with an hyperlordotic function. And it is key for viscoelastic implant because the viscoelastic implant provides you the lordosis you want. And if you have hyperlordotic patient due to high pelvic incidence, we must know that probably we should provide a little bit less lordosis than what was expected at the beginning. This is what I have seen on the EOS. And so I think it is interesting to look at the standing and sitting patient to analyze their function before the surgery. Don't use only CT scan or MRI.
So we don't need to have EOS all the time. We can just make a regular X-ray, sitting position and standing position.
Yes, we did this at the beginning when we use this for hip, for example. You can calculate easily pelvic incidence. Even if there are small mistakes for the angle, it's not a problem. You must be able to detect a high or low pelvic incidence patient. And with this, you are able to analyze the sacral slope. What is the difference between standing and sitting?
And don't forget to analyze also the hips because, as you said...
For example, this patient moved from a hip user before the surgery, and he moved to a spine user with less flexion of the hip. And it is very interesting what Svante said. We must continue to follow those patients because after this, they become lazy. They use less their hips, and they become with muscle retraction on the subpelvic area. It's interesting to follow them.
I have one more question from the chat. Is the posterior longitudinal ligament always preserved or removed with a viscoelastic disc prosthesis? Do you remove the PLL when you make a prosthesis using a viscoelastic model?
I never deliberately take it away. Normally it's still there, but it's shrunk since the disc height is low. Sometimes there is holes in it from disc herniations and this and that, but I always preserve as much as I can of it. It's not an enemy of me. It's rather an added structure for stability. So I would not take it away, but sometimes nature has taken part of it away before I'm there.
But when he's shrink, as you said, you don't try to lengthen or to cut it.
When I distract between the vertebrae, it de-shrinks.
It depends. I do it when the prosthesis does not perfectly fit on the vertebra. I prefer to cut it to have a perfect fit between the vertebra and the prosthesis.
When you don't reach the posterior rim of the end plate, when you cannot push your prosthesis too far away posteriorly, then you remove the ligament. That's right?
Yeah.
Okay.
Yeah.
And Jean-Yves, what do you do?
Very often, this ligament anatomically is not very strong. Sometimes it is calcified, so I do distraction, and we hear the crack, and very often it is sufficient. But we must do a good release posteriorly to put the prosthesis in the good position. At the very beginning of my humil experience, I had some slipping of the implant because I did not, at the very first cases, I was anxious to remove or to crack this ligament. When we put the prosthesis sufficiently posterior, it works very well, easily.
Okay, we move another question from the chat. Do you use TDR in patients with prior operation? Or for the three speakers? Yes. 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 Okay. Well, it depends what kind of operation, I guess, but of course, discrimination, or even when we are skilled, we have to sometimes to revise some disc prosthesis, which is very difficult surgery. But
and also on adjacent segment disease, for example, if you have a 2-segment fusion that develop probably 2 segments of ASD on top of it, I would be happy to revise it with TDR.
Okay, so I think we must conclude. We are just on time. So I hope you enjoyed this original focus on spine alignment and disc arthroplasty. And I think, as I said before, we have heard new interesting ideas on that matter. So I look forward to meet you again on the next spine webinar, or hopefully in a presential meeting in a few months or next year. And I thank you, all of you, for your participation. And take care and goodbye.
Goodbye.
Bye.
Goodbye.